and good morning, everybody. It's always difficult to follow Sadaf and also Stuart and also listening to Lisa earlier, the patient experience. We've had a really good set of talks this morning. I'm hoping what I will be able to do in the next 25 minutes or so is try and bring some of that together. And hopefully then at the end, there'll be time for a really good panel discussion, because I think the interaction between all these different aspects is really very, very important. So what I want to do, what I've been asked to do today is talk a little bit about obesity. How common is it? Why does it matter? And I think there's going to be an interesting discussion here with Stuart and the comments that he made about the burden of obesity and the fact that may be a part of the negative stereotyping. And yet I do feel that we have to make that argument to the policymakers that obesity is important. And so we have to use appropriate language. And I think that's going to be an interesting discussion, because one of the reasons why we're all here today is obviously there are individual people living with obesity where they need our help as healthcare professionals to help them lead healthier lives. But at the same time, we have to persuade the funders of our health service to actually put money into supporting that treatment. And unless we can demonstrate the costs of that to individuals, to society as a whole, it's very difficult to make those arguments. I also want to talk a little bit about some of the causes of obesity, and there will be some overlap with what we've heard from both Stuart and Sadaf, but I would like to maybe bring in some other aspects that perhaps others haven't thought about. And then I want to focus a little bit on some of the mechanisms whereby obesity leads to other diseases, which ultimately is one of the reasons why the costs for individuals and for society are so high. We've already seen similar versions of this slide before, but I make no apologies for showing it again, simply because I've been asked to talk about epidemiology. And one of the things that we have seen and really have to recognize that has happened over the last 30 or 40 years, this is a world map of obesity prevalence. You can see that the red is between 20 and 25% between the 1960s and the 1990s. And you can see that there were a few hotspots in some parts of Central and South America, parts of the Middle East, and parts of Europe, even at that time. But what has happened over the more recent years is that this has become much more common, and we have a lot more countries now in the red region. And in fact, we probably need even more colours to demonstrate the fact that in places like the United States and here where we live in the UK, we now have a prevalence of obesity as defined by body mass index, with all of the limitations that come with that, of approaching 30%, and in many countries now exceeding 30%. We also have to think about children. Those figures I've showed you are for adults, but one of the things that is done for population monitoring in the UK is to look at, we now have the National Child Measurement Programme, which gives us a lot of accurate data around the weight of children. And you can see here the definitions that are used for that population monitoring. And we have those individuals who are in the top 5%, if you like, 95th percentile, that would be included in that severely or obesity and severely obese categories. And if we look at children, again, we see the same pattern where that prevalence has increased from really only a few countries in the red zone to more currently where we have pretty much the whole of the Americas in the red zone, very large parts of Middle East, North Africa, Asia, and Europe, with a very high prevalence of childhood obesity. And of course, those young children with obesity are going to become adults with obesity, and they are likely to develop the health problems that we all know about. Stuart mentioned the WHO definition, and I do apologise for repeating that and the word abnormal, but that is the definition that is currently used by WHO, and in fact has been used by WHO for I think more than 70 years. So it's defined as an excessive fat accumulation that may impair health, and we use body mass index as a surrogate for that. And body mass index has a lot of flaws. It was designed as a way of estimating health risk for insurance purposes in the 1920s. And that is the origin of body mass index. And it is imperfect because it doesn't tell us about body fat. It doesn't tell us about function. It's a very weak surrogate. The problem that we have is that most of the epidemiology on which we base our clinical decision making and our epidemiology and our policy decision making is based on body mass index, because measuring body fat accurately and measuring its distribution accurately at a population level is much more difficult than measuring BMI, or even if we use another measure such as adding waist circumference or waist to height ratio, which NICE is considering recommending. All of these things have the same limitations, that they don't actually tell us how much body fat we have, they don't tell us about its distribution, and they don't tell us about its function. And of course, if we're thinking about obesity as a disease, we have to think about the fact that it's not just how big you are, it's also about where that fat is distributed, because we know that, for example, if you are likely to put fat in the abdominal region, that's more likely to be associated with fat deposition in the visceral organs, such as the liver, the pancreas, muscle, and so on, that then affects function. And that may also be associated with inflammation. And as I'll show you a bit later on, Sadaf has talked about the genetics of obesity. There is a completely different set of genetics that determines fat distribution. So it's, in fact, another layer of complexity to add to what we've already heard about. Just the other point to make here, while I'm just talking about the general epidemiology and trying to set the scene, is the fact that for different populations, we've tended to use different classifications. So if you're living in the Asian Pacific region, or if you're from those backgrounds, then these slightly lower cutoffs are used to define obesity using body mass index. And that's based on the fact that some of the complications of obesity, particularly those that are related to metabolic disease, diabetes being really the number one here, seems to occur or does occur at a lower body mass index, but maybe that's because of different fat distribution in those populations. So again, another layer of complexity that we have to remember and think about. Another point that I wanted to make, we've talked about the fact that obesity has been becoming more common. And this is a very large study. There's a lot of detail in this paper, and I haven't got time to describe it all in a huge amount of detail today, but this is the non-communicable diseases collaboration, which has used as much information as it can get from a huge number of population studies, over 2,000 population studies in over 128 million individuals around the world. And what it's looked at is that rate of increase of obesity in those different environments, in those different countries. And what we've seen is that in the Western world, so this would include us in Europe, in North America, and in some of the higher Far East countries like Singapore, for example, we've tended to see a plateauing in that increase. We maybe have reached a plateau. But in other parts of the world, particularly Southeast Asia, but also now increasingly we're starting to see this in Africa, in sub-Saharan Africa, where the health services are really not geared up to deal with the complications of obesity. They're geared up to deal with communicable diseases like malaria and so on. They are starting to see a very rapid increase in obesity. And of course, they don't have, we complain that we don't have enough support for individuals, but in those countries, it's going to be even worse. And I think that's something that we need to bear in mind as well if we're thinking from a global perspective. Coming back to the UK, although we've seen a plateauing in the general population rates of obesity, it's been hovering around 28, 29% for the last 5 or 6 years. What we haven't yet seen is a plateauing in the number of people living with severe obesity as defined by a body mass index above 40. And you can see that here, the red line is women, the green line is men. This is UK Health Survey for England data. And you can see that it is just continuing to increase. And that means that if we consider nice guidelines for bariatric surgery or for some of the more recently available drugs that are coming online, the numbers of individuals potentially who could benefit from these treatments is huge. And yet we know from the National Bariatric Surgery Register, for example, that 2 million people with severe obesity, about 5,000 operations pre-pandemic per year. It's going to take us a long time to offer effective treatment to 2 million people if we're only doing a tiny percentage each year. We've seen this diagram before, but I think this is an important way of thinking about the complexity of all of this. This is the Foresight report that Stuart mentioned earlier. And without dwelling on that for any length of time, I think this part of it actually kind of describes this. Now, at the middle of this is the part that Sadaf was talking about. That's our appetite control system. That is the individual internal physiology that is so important. But outside of that, the wider societal determinants, some of which are related to our individual personal biology, but most of which are things that we have absolutely no control over. Whether we have what we eat is what's available in the supermarkets largely, or what we can buy in takeaway food or in restaurants. But what is produced comes from the policies that are set for the farmers and for the other and for the food manufacturers. How active we are as individuals has changed dramatically as well over the last 50 years. I mean, I remember there's a figure that's quoted that the average person in the 1950s would walk in an average week the equivalent of a marathon distance, so 25, 30 miles a week, whereas now most of us walk much less than that. So our physical activity has dropped as well. And again, that is something that as a society we can do something about. But at the moment, the policies seem to be driving us towards doing more, driving our cars more and being less physically active. So we have to think about policies that relate to the food environment, but also to the physical activity environment. And there are lots and lots of those individual pressures that are pushing us as a society probably still in the wrong direction. And of course, there are some quite important things here that actually link this back to other policies. So our policies around global warming actually have to do with the physical activity environment, because if we use active transport, we'll be using less fuel, whether that's driving an electric car or a petrol-driven car or a diesel car or whatever, or getting in a train, that's still using energy. If we can shift to more active transport, that's going to be good for us and for the environment. If we shifted food policy more away from meat-based diets, more towards plant-based diets, and I'm not a vegetarian, but I think these things are actually probably going to be helpful for us as a society to have less energy-dense foods available to us. But the policy drivers mostly are pushing things in the wrong direction still. And that's to do with taking that responsibility, as Stuart was talking about, from the individual and giving it to society. And that, again, that's something that at the moment is quite difficult to achieve. We've already heard a little bit about this from Sadaf, but I do think it's important just to remember that the internal biology is really important. To maintain body weight, we have to be in energy balance, but the things that influence energy balance either one way or the other, some of those are the biological part, which is partly our genetics, but it may also be other damages to the biology. So a tumour that damages the hypothalamus or a brain injury can contribute to obesity. Some medications that we take can contribute to obesity. But that only happens within our own individual psychological status, again, which interacts with the biology in quite complex ways, as we've just been hearing about, but also the social context, which is very important and much more difficult for us as individuals to control. So as Sadaf has already said, I'm going to skip over this fairly briefly because we've already heard this. Yes, body weight is highly heritable and very close, particularly in monozygotic twins. But if you look at studies of populations and you look at the whole range of genes, so you do what's called a genome-wide association study, there are probably a couple of hundred or even more genes, most of which are in the brain, that seem to influence body weight. If we look at the people who have the highest number of obesity-related genes, you can give them a score and you can say, well, if you've got a low number of obesity-related genes, then your score might be 1. If you've got a very high number, it might be 10. And you can then look at across populations and say, well, let's see here, if you're in the severely obese category here, so people living with severe obesity, it's 5.6% of the population, but much more of those are in the top decile for the genetic part of it. Whereas if we look at people who are in the healthy weight category, which is this group here, this group, tiny group here is the underweight category. The healthy weight category, they have a much lower genetic risk score, so they're much more likely to have to be in the bottom decile compared to the individuals. But what that is also telling us is that you can actually have quite a high genetic risk and still not be living with obesity, but you can also be living with severe obesity with a low genetic risk. So the genetics is quite good for populations, but it's not very helpful for individuals. And in fact, you can actually estimate that. So even if you're in the 90th centile for the genetic risk score, the positive predictive value is only 40%. So it's really very low and it's not very helpful. So anybody who goes suggesting that we can send your genes off to a laboratory and that we'll do a gene profile and tell you that you're likely to develop obesity or not, it's mostly nonsense. Obviously, if you have a single gene disorder, as Sadaf has described, then that's a very different situation. But for these polygenes, which is probably most of the people that we're seeing in our clinics, don't have an MC4 mutation or something like that. The other 299 out of 300 who don't have that. This is not going to be that helpful. And the other part of this, which is important, it is the fact that, as I say, fat distribution is also probably another separate set of genes. I just want to spend a couple of minutes then talking about a study which is quite an old study now, but I think demonstrates the power of the environment, even if the genes don't change. And this was a study that is a longitudinal study published in the British Medical Journal a few years ago that looked at what happened to the population of Cuba before, during, and after the economic crisis that occurred when the Soviet Union collapsed in 1990. And what this is looking at here is during that time, there was a very sudden change in the environment. So nothing happened to people's genes, but suddenly there was a massive recession, very sudden, massive recession. There were genuine food shortages. Public transport pretty much collapsed because there was no fuel. There was a massive increase in physical activity. Personalized transport, they imported 1.5 million bicycles from China. And you can see here that this is the dietary energy intake of the population, the red line. And you can see before that it was round about 3,000 calories a day. and it dropped really quite dramatically. So you've got the whole population, the average dropped by about 20% dietary intake because there just wasn't enough food. The proportion of the population that was physically active increased massively from around 30%, which is probably about where we are now in this country, up to nearly 80%. And then once the economic recovery occurred, the physical activity dropped off and the food intake went back actually to above its previous levels. And if you look at what happened to obesity, these are the distribution curves of the population, and you can see pre is the blue line, and then 1995, the whole curve has shifted to the left, and then it shifted back to the right again. If you look at this in terms of obesity prevalence, that's the blue line here. It was running at about 15%. It dropped to around 7% and then increased again. And you can see what happened to diabetes prevalence, which kind of leveled. The increase was slow, it leveled off. And then as soon as the recovery occurred, diabetes suddenly became a lot more common. And if we look at incidence of diabetes, you can see the incidence of new cases actually dropped and then increased. And the mortality, there's a lag there, but actually that fell later on because of, obviously it takes a number of years from diabetes to lead to mortality. So that just shows how important the environment can be. Another study that kind of just demonstrates this quite nicely, again, it's another quite a complex study, but it's a longitudinal population-based study from one area of Norway, where they actually followed the population in cohorts going back to the 1960s. And so they had this whole population of more than 100,000 people where they knew what their BMI was, and then they were able to do a genetic analysis on about half of them for 96 of these known 200-odd obesity genes. And then they were able to look at the associations. And it's quite interesting what was seen there. Because if you look at the trends, we can just look at the men, it doesn't matter, you can look at men or the women, but you can see that the trends in body mass index for those cohorts that were, the younger cohorts are much steeper than for the older cohorts. So those people that were brought up in the environment of the 1960s, 1970s, the increase in body weight is relatively flat, but for the more recent younger populations, it's been much steeper. And again, this is showing how this has very rapidly changed over time, although the genetics of the population haven't changed. And although the older cohorts are showing some stabilization from middle age, we're not seeing that in the younger people. And again, that is going to drive increase in the complications over time. And if you then combine that information with the genetics, what you can see is that the most susceptible individuals in that population from a genetic perspective were the people who had the biggest rise. So the prevalence of obesity in the most genetically susceptible quintiles, just taking men from 35 to 45, but it happened in all groups, rose from somewhere between nearly up to 30%, whereas in the least genetically predisposed, it rose from a lower level. So it rose from about 2% to about 13%. So it increased in all the cohorts, but those most genetically susceptible have a much higher prevalence of obesity. So that's how the genes and the environments interact. And the conclusion from this study was that the genetic predisposition gives you a higher risk of a higher BMI, but the BMI is increased for the whole population, but those who are most susceptible have increased to the greatest. But the biggest contribution over time, of course, is the environment. And this is just the data showing about the genetics of fat distribution, a different study here. If you look at waist-hip ratio and genetics of BMI, you can see that actually the BMI is quite strongly related. But if you start looking at the fat ratios, that they're completely different. These are almost completely separate groups. So you have to not just think about the genetics of BMI, but also about the genetics of fat distribution. So the next part I wanted to talk about relates to obesity and disease. And we could list all of the diseases associated with obesity. They're not all in this table, but there are very large numbers of conditions. And it's worth thinking about it from a mechanical, so in other words, what happens when your body is actually having to move extra weight around? This causes a higher risk of, for example, osteoarthritis, symptoms related to the joints and the musculoskeletal system, which lead to pain. It affects our respiratory system. So we have problems with breathing. People often report breathlessness. I can recall we did a study a few years ago where we recruited people with a GP diagnosis of asthma. And then we did a detailed respiratory studies to see whether they had airway hyperresponsiveness. And what we found was that a very high proportion of those individuals with the diagnosis of asthma actually had no evidence of hyperresponsiveness. They were just living with obesity, and that was causing them to be breathless, and that would be incorrectly considered to be asthma by the GP. The other respiratory condition, of course, that's very strongly associated with obesity is obstructive sleep apnea, and that also has an interaction with metabolic disease such as diabetes. And another huge problem from a healthcare perspective that is becoming increasingly recognised is the association between obesity and high risk of having an abnormal pregnancy, diabetes-related pregnancy, obesity, obstetric-related complications, and so on. All of those are strongly related to obesity. And then the fat distribution part really comes in when we start thinking about the metabolic consequences, the type 2 diabetes, the cardiovascular disease, non-alcoholic fatty liver disease, or metabolic associated fatty liver disease, as it's now better termed, problems such as polycystic ovarian syndrome, problems such as infertility, and of course a whole range of cancers, particularly those that are hormone dependent, so estrogen dependent cancers such as breast cancer and endometrial cancer in women, prostate cancer in men, are very strongly associated with obesity. And partly because of the stigma, there is also, and partly because of the socioeconomic issues associated with obesity, there is also significant mental health problems. And of course, all this has been brought into very stark highlight by the COVID-19 pandemic. I'm not going to show you lots of data about COVID because we're all sick of hearing about COVID. But there was definitely, you were more likely to catch it. You were more likely to end up in the hospital. You were more likely to end up in intensive care. And you were more likely to die if you were living with obesity compared to people who were not living with obesity throughout the pandemic. However much you tried to correct that for socioeconomic differences and other diseases that may have been associated with poor outcomes, such as diabetes. And the other point to make here, which is what these kind of yellow arrows are showing, is the fact that these things all interact. And certainly when I look at the populations we're looking after in our services in Liverpool, about 80% of the people that we're seeing are from the most deprived 20% of the population, and most of them have more than one obesity-related complication. And you can see how this is happening if we start looking at things like diabetes across the world. We can see there is an increase in the number of people with diabetes, which is very closely maps to the increase in obesity that we've seen. And if you look at the epidemiology between obesity and type 2 diabetes, it's very clear that this is very strongly related to body mass index. And it's partly also to do with where you put the fat, which again is a separate set of genetics. But if you are somebody who tends to put not a lot of subcutaneous fat in this individual, but a lot of intra-abdominal fat, but that may not be totally the whole part of the pathogenesis. A lot of it comes down to where that fat is distributed. If there isn't much space in the subcutaneous tissue, there's more storage in the intra-abdominal tissue, but there's also another form of storage within non-adipose tissue, so within the liver, within the muscle, and even within the beta cells. And some of you who will be familiar with the work of Roy Taylor and colleagues will know that there is this hypothesis that it is your fat deposits within the pancreas that are causing the beta cell dysfunction and that ultimately lead to the development of type 2 diabetes. And of course, that can be reversed to some extent if you catch it early enough with weight loss. There is also a concept that we need to think about, which is the fact that if you accumulate additional adipose tissue, particularly intra-abdominally, but again also within the organs, then that becomes dysfunctional. And it seems to lead to inflammation, not just within the adipose tissue, but also within the systemic system. That includes within the arteries. And this can then contribute not only to the development of diabetes through the mechanisms that I've just mentioned, but also to the higher risk of cardiovascular disease because of the development of atherosclerosis. So the links then between obesity and metabolic complications are quite complicated. And again, there are interactions at the genetic level with fat distribution, with the predisposition to inflammation, with things like our genetics of our cholesterol. And again, this is why it's not simple. If you think about cardiovascular disease, you can look at this in an epidemiological way. And this is quite a nice study that demonstrates that the occurrence of cardiovascular disease in people with obesity is partly driven by risk factors, but is also separately driven by the presence of obesity. So if we look at, this is taking this the reference group, if you like, people of a healthy weight, but without any of the metabolic abnormalities, so that be hypertension, diabetes, dyslipidemia. And if you then look at the people with 1, 2, or 3 metabolic abnormalities, you can see that, of course, the more metabolic abnormalities you have, the higher risk of cardiovascular disease. But if you then look at how that interacts with body weight, so I'll go back here. So in the healthy weight people, we can see that exists. It also exists in the people who are overweight, and it also exists in the people living with obesity. But if you look at those individuals who have no metabolic abnormalities, as you rise from healthy weight through overweight through obesity, there is also an increase in cardiovascular disease risk, showing that independence. And the same is true here for cerebrovascular disease, for stroke, exactly the same relationship. So obesity is driving this independently of its effect on the other risk factors. And the same is true for heart failure. You can see this for heart failure as well. Normal weight, overweight, obesity, with or without the metabolic abnormalities, the higher the risk of heart failure independently of that. And as I've already mentioned, this is probably happening through these mechanisms, this excess and hypertrophied adipose tissue driving ectopic fat deposition and ultimately also leading to atherosclerosis. The final part I want to mention about before I finish relates to the economic aspects of this. And this was a study from McKinsey published a few years ago, which lists one of the, again, using the term that Stuart doesn't like, 3 global social burdens generated by human beings. Number 1 is smoking, number 2 is armed violence, war and terrorism, and number 3 is obesity. So pretty high up on that list, and smoking is decreasing in prevalence. So we may soon find that this becomes second. As part of the work that I've been involved in as my role with the World Obesity Federation, we published this paper a few months ago looking at the cost per capita of obesity on the whole of the society. So the cost varies quite a lot. We looked at 8 different countries with different economic backgrounds. So the cost per capita in India is much lower than the cost per capita in Australia. But if you then relate that to GDP, it's approaching 2% of GDP, which is not insignificant. And this just shows this across the different countries. So you can see here, we've got Australia, Brazil, India, Mexico, Saudi Arabia, South Africa, Spain, and Thailand. So quite a range of countries here. And you can see that for all of these countries, the cost of the percentage of GDP is around about 2%, being much lower, of course, in India, given that there's probably a lower prevalence, and the cost per head of population is pretty high. So to summarize, I would like to remind you that obesity is a disease. It's common. It's increasing almost everywhere in the world. It has serious complications. I focus a little bit on type 2 diabetes and cardiovascular disease, but they're not the only complications of obesity. And the cost to healthcare systems is largely through the complications. It's also important to remember that the underlying biology is really important here. That's partly genetics, not just about fat, but also fat distribution. But the reason why we've got an epidemic is because of the changes that have happened in society. And we're going to have to do some pretty fundamental things to our society if we're going to reverse those trends. But in the meantime, I think we have to think about obesity as a disease that we think about just the same as every other disease that we treat, which means that we need to find the funds to appropriately support and treat people living with this disease. That is my last slide. Thank you.